I really want to talk about women's health and really some of the opportunities within women's health to address really sort of care across the entire continuum. And so I want to sort of introduce the group to Cassie. So Cassie began her prenatal care at 12 weeks of pregnancy. She had had one vaginal delivery and one C-section in the past, and honestly was feeling groovy. She was really looking forward for her daughter and her son to have a younger sibling. On her routine lab, she was found to have a hemoglobin consistent with anemia. Her OB provider, rightfully so, recommended iron, which she took most of the time. At her 28-week visit, her blood was redrawn and her hemoglobin was found to be unchanged despite iron therapy. She was referred to see a hematologist, which she called to make the appointment. And the first available appointment was 3 months from now. And she put herself on the wait list and sort of crossed her fingers that she would get an appointment sooner. Time just flew by and she began feeling contractions at 38 weeks. And just as she had hoped, she had a pretty quick vaginal delivery. A beautiful girl, Annika, 7 pounds, 2 ounces. But at that time, right after delivery, she had a hemorrhage of 600 milliliters, which resolved with medication. She was worried about what had happened, but was glad that it had resolved so quickly because the labor and delivery team had responded so fast. She made it to the postpartum unit for observation, like all patients do, and she was gearing up to breastfeed Annika when she started to feel more sharp pains. She also experienced lightheadedness that just wouldn't go away. She alerted the medical care team, which rushed in to care for her. After doing a bedside ultrasound and also reviewing her labs or her vital signs, the OB team realized that her blood pressure had been low for several hours, but no machine or no person had alerted anyone. The exam revealed a uterus full of clots and they were removed. She was really uncomfortable, but she didn't say anything because she was scared. Several units of blood later and additional medications later, the bleeding stopped. And she felt better, thankfully, due to the transfusion. And she was really glad that Annika had slept almost the whole time in a bassinet nearby during the whole ordeal. She wasn't really sure what had happened, but she was glad it was over, and she went back to the business of bonding with her newborn. 2 days later, Annika and Cassie were both discharged to home. They received a packet of instructions about this big on all the things to look out for. They got settled back home. Allison and Alex, her other children, were in love with their new sister. She Googled postpartum hemorrhage, but it was scary. And so she decided to just close her laptop and never looked at it again. 8 days after delivery, she began to have a few sharp pangs and a little extra blood. She started to panic. Was this normal, or was this the kind of stuff that she should go to the hospital for? She called a friend to come over and made a cup of tea. Thankfully, the symptoms passed. She took a sigh of relief, and she couldn't help but think, was there anything that could have been done sooner or earlier in pregnancy that could have made this easier? And also, why was it so hard to understand? Unfortunately, Cassie's story is not uncommon. And as we all have seen in the media and elsewhere, maternal morbidity and mortality continue to remain a true public health crisis, with Black and brown birthing persons nationally experiencing higher rates than other counterparts. And so while there's a lot of emphasis on mortality, as there should be, for every severe maternal mortality, there are 70 birthing persons who experience a severe complication, like a maternal hemorrhage. And the vast majority, about 80% of these morbidities and mortalities, are indeed preventable. And so recognizing that we need to think differently, diagnostic safety science has emerged with tremendous promise as a way of advancing safe maternal care. And so what is diagnostic excellence? Simply put, it's accurate and timely identification of a health problem and effective communication of that health problem. There is so much attention around this that the National Academies hosted a workshop on the topic of diagnostic excellence. And Biden's Presidential Council of Advisors on Science and Technology issued a safety report, which included a focus on diagnostic errors. Now, diagnostic safety is not new to medicine. It just hasn't been really applied well in women's health, and certainly digital technologies can really advance diagnosis. About 800,000 diagnostic errors occur in US hospitals, and 1 in 20 individuals who receive outpatient care will experience a diagnostic error, sometimes without harm, but will experience an error. So as we look on this call, a handful of us, right, at least will experience a diagnostic error this year. And so the diagnostic process, this also comes from the national academies, is mapped out like this, right? From the time that someone experiences a problem all the way through the evaluation and communication. And not only do tools and technologies have to think about that diagnostic process, but sort of the various ways in which people experience care and all the tools and the physical environments and the team members that are involved. And so Cassie's journey that I shared with you, there were several opportunities to improve diagnosis, and I'm firmly convinced that our technologies and tools could have helped at each step. The first was early and thorough investigation of her anemia. It didn't change at 28 weeks, and yet when she called, the appointment wasn't available for 3 months, right? And so this should have prompted earlier evaluation, given that pregnancy is a time-limited condition. There was an opportunity for communication and coordination of care through hematology, but also in sort of talking to Cassie and her support system about sort of opportunities to address anemia. A preparation for high-risk scenarios. Cassie came into the hospital for her delivery with known anemia. What could the readiness have included for this high-risk scenario? And then, as mentioned, right, her blood pressure had been low for hours. She'd been experiencing symptoms for hours in the postpartum care. And how could our tools have helped flag that earlier? And then the post-discharge follow-up and instructions, right? Rather than a stack of papers, what can we provide to both patients and care teams to make this journey easier? Now, I'm heartened again because I'm in a room of innovators and improvers. And I'd like to provoke the audience to really think about some solutions that can help address the nonlinear diagnostic process. And so here are a few sort of ripe targets. Enhanced risk prediction and early recognition of problems, improve coordination and collaboration amongst the various types of care providers that see patients during pregnancy, elimination of disparities, including inadequate access to care, development of data infrastructures that really help capture the nature of diagnostic errors and events that happen, best practices for remote monitoring, inclusion of pregnant persons in the development of technology, and materials, education, training, other supports that help accelerate the understanding of the diagnostic process. And so, as I think about this wonderful audience and all that we can do together, we can and we must do better. And I have no doubt that digital technologies, especially those that advance diagnostic excellence in maternal care, is one way of doing just that. And so I look forward to the continued conversation.